let's continue with our exploration of AI in healthcare. I'd like to introduce our moderator and our panelists for the next panel. Our moderator is Alan McKellar. He has more than 24 years in product development across many industries, and he is going to be leading the panel today. Additionally, on the panel, we have Walter Greenleaf, who's a PhD. Walter Greenleaf is a neuroscientist and medical technology developer at Stanford University. With over 35 years of medical research and product development experience, Walter is a leading authority in digital medicine and clinical virtual reality technology. His expertise is in a wide range of clinical sectors. He's developed systems that address a spectrum of conditions, including post-traumatic stress and anxiety disorders, stroke, addictions, autism, depression, and many other challenging problems in behavioral and physical medicine. In addition to his research at Stanford, Walter is the technology and neuroscience advisor to several early-stage medical product companies and investment groups. Welcome, Walter. We have Alaa Youssef at Stanford also. She's a postdoctoral researcher specializing in AI ethics, healthcare AI, and human-computer interaction, with a strong focus on responsible AI evaluation and user experience for large language models. She excels in creating value through leading interdisciplinary research and practical applications that align AI development with ethical standards and public health goals. And then we've met Ram Menon earlier, so we won't go through, but just a reminder, he is a foundation and CEO of Avaamo, and we saw his wonderful presentation earlier. So with that, we'll turn it over to the moderator, Alan McKellar.
Thank you, Robin. It's a pleasure to be here on behalf of the panelists and myself. Thank you for having us. Before we get started, just to get a sense of who's in the audience, I'm going to ask by a show of hands, who here is a developer? All right, and who is a designer? All right, how many of you are healthcare professionals? Okay, quite a few. So we've got a really wide stakeholder audience for today. So thank you for coming here and sharing your time with us. I'm going to start off with the first question for our panel around, what are you working on currently?
I think what we're doing is we're moving into what you saw with my presentation, some of you did, is, there is a focus on self-service for the patient. And now we're looking at self-service for the clinician. That's the next phase of AI, making the clinician's job easier.
Fantastic. Thank you, Ram. How about you, Walter?
Well, it's a little complex. I'll try and be brief. I'm in the fourth chapter of my career, and I'm trained both as a neuroscientist, behavioral neuroscientist, but also a technologist doing a lot of work in psychophysiology and digital health technologies. I'm also a medical product developer, and I've had the pleasure of bringing several medical products to a successful exit. So a lot of what I do right now is translational, working with many early stage companies and academic groups, helping them get started, and then also helping the healthcare networks, the pharma, medical device, and other players in our arena understand what's coming through and trying to connect the dots and make sure that breaking the ice for that pathway, making things go a little bit faster. And it's a very exciting time for that because we're picking up so much speed, see so many exciting technologies that are just coming out.
Fantastic work. Thank you. How about you, Alaa? What are you working on?
So I work in multimodal vision language model in radiology, and as well as large language models evaluation. Particularly, I work on the clinical evaluation, so how these models really result in clinical outcomes that are accurate and reliable for physicians to rely on. A lot of it is also around the ethical considerations. So as we integrate products that are coming outside the hospital or Stanford Healthcare Medicine, what are some of the ethical or data considerations we would have? I work as part of a large data science team, as well as I work at the Stanford Amy Center, leading some of the ethics and policy research, and some of that is around how we govern generative AI and general governance of AI in general.
Fantastic. Thank you so much, Alaa. So the next area I'd like to talk about is adoption. So earlier today, we heard during the enterprise panel that there are some barriers to adoption, even though the cost of entry is getting lower. And what Ron had mentioned is that there's data privacy concerns, concerns around the bias in data sets. What other issues come up and considerations that inhibit the adoption of AI in healthcare in particular?
Well, from my point of view, there are tremendous concerns. I mean, we have the general topic of ethics, of course, but within that, as we get better at understanding using machine learning and biosensing and analytics, there's the issue of personal privacy. Psychiatry and psychology are going to be empowered by our ability to look at voice tone, facial expressions, body language, heart rate variability, all these signals that can be captured unobtrusively and analyzed. But it's such precious data about our intentions, our goals, our aspirations, our limitations that can be used by other people to sell things to us or to discriminate against us or decide who's hired, who's fired. So within the subset of your question, I think the data privacy issue is paramount and one of the challenges I think we're all facing.
Good point, good point. What other considerations are there that are holding organizations back? Because we've heard some really compelling examples. We had a demo from the micro robot being swallowed, making a difference. You know, what other considerations?
I think I can mention about organizational readiness. So in a study we did to assess across the United States 18 organizations to understand what actually motivate or make organizations ready to adopt AI or do data sharing. And a big component of it is about what organization capabilities you have and organizational leadership and motivation to adopt. I think the capabilities is something we need to think about in health systems that are not the Ivy League or resourceful health systems, because those health systems do not have the infrastructure that allow them to adopt these types of technologies. So there's one component of that, and then there's the other where how do you educate your workforce to be ready to adopt these kind of tools responsibly and use them as part of their workflows. So at Stanford Healthcare, we developed actually one course and have deployed that, and that's the goal of training people in technology and digital solution to understand what AI is and how they can use it productively in their workflow to kind of improve their productivity.
Fantastic. Well, we do have a couple of questions. One is tied to the previous work, and Ram, I think this question is for you. What AI tech and solutions can help with reducing no-shows other than being able to cancel appointments, a huge part of revenue loss for healthcare systems?
Yeah, I don't think, so the way we've been doing this, like I said in my presentation, we did 200 million unique patient journeys. And the data that comes out of it is, human beings just gonna do a no-show. They're just gonna do a no-show. So there's always going to be a certain percentage of people just failing to turn up. But if you could make the experience easier, right, to just engage, it's really easy to use Google Pay, right? Like, can you get to that level of ease? And that's really what matters. And that's what we've seen. If you can make the experience easier, is it a voice experience? Is it inside the app? Or is it a single button click? Whatever it is. For example, we've created a whole conversation that can be generated from a single SMS. So all these things is just simply about making it easy. Like this whole thing we talk about AI, I live in the real world. I'm a for-profit company. So when you're a for-profit company, you're always looking at it. And I think the biggest issue, data privacy, is going to get solved. Most of the data Doctor mentioned is not going to be used for training. But there are two things, right? Organizational readiness is terrible in healthcare, right? Most people in the organization are still in the 1990s, right? So organizational readiness is one side of the equation, and the other side of the equation is ease of consumption. Those are the two things. So, you have a lot of startups that trying things, but and people use the cheapest software. That doesn't work. You have to have well-crafted software that makes your end user want to use it. And that, I think, is a significant problem.
I'll put a layer on top of that. I think we're entering an interesting era. A lot of my work is on using immersive technologies. And what we're seeing compared to using a mobile app or a computer-based app is more adherence. And we're at the point right now where we can put a layer of storytelling on top of the healthcare journey. And I'm not talking about gamification per se, although that can be part of it. But I think what's lacked, because we've been scrambling so hard, as we move more digital technologies out, the patient experience or the client's experience can be made a little bit more robust in terms of being engaging. And we can have, depending on the person's choices and personality, things that help them along their journey. Dealing with cancer, dealing with a chronic disease, all that is very challenging, especially if you're on your own. But if you can bring together people in different contexts and create a way of providing information and support in a way that's not Xerox sheets of paper or showing up at a user group or a post-discharge follow-up meeting. I think we can do that with technology now. So I think we're at the starting point. Looking at some of your characters is a great example, but we can extend that out to more of an engaging experience that promotes adherence.
Absolutely agree with you. So here's an interesting anecdote. We do an agent, like the agent you saw when I was presenting, for a hospice center in Atlanta. Remember, it's a hospice. And I wanted to take it on, right? It wasn't a profitable account, but I wanted to do it for that. And here's the anecdote. Here's the punchline. My engineer spent 2 months fine-tuning tonality. And the tonality had a 45%, because of just the tonality. Because hospice, it's all the protocols are pretty much set in stone. But the change in the tonality to what the doctor was saying, there was a 45% increase in approval ratings, right? So these things matter. Empathy, tonality. It's not the technology. It's how you engage. That is now the big issue.
I think if I can add something onto that, so it's important as we kind of also, be able to see like who's under the no-show, is to understand which populations are not showing up and addressing the infrastructure issues. Because, for example, UCSF and many of the big organizations, healthcare organizations, they have built robust systems where they are able to see that specific patient groups have challenges that's related to social determinants of health. So it's one also component around where CMS can help with reimbursement and healthcare planning, but also how do we address the infrastructure and social determinants of health. So it's, to me, also an infrastructure.
It's a great point. I agree with you. So I'll give you an example. So what you said, you get these interesting data, right? So we used to do COVID appointments for the state of Massachusetts, and we did a lot of appointments, and it was a crazy time there. So one of the things, following your point, they found was people of Vietnamese extraction were only booking appointments like only 2%, right? So, hey, there's a choice there for the language, but they were not booking appointments. But we were able to do the analytics and figure out that people of Vietnamese extraction in Massachusetts want group appointments. And we don't think about it like, I could do an appointment, my wife could do it next Monday, but so these are some interesting social things that that we discovered using analytics, that actually, like, in the old way of doing things, hey, you have a language choice, that's good enough. Well, that's not good enough.
And I think the key word you used is analytics. We now have the tools to look at and understand where the problems are and design to promote it.
So now, great point, right? So many of you in this room are aware of BI tools and Microsoft's Power BI. Now there's a new emerging area of conversational analytics. And that's not just sentiment analysis, but the behavior or the way in which people respond to things can give you some very good insights. So conversational insights or conversational intelligence is a new area of research that we're looking at to say, how did they respond? So how did we respond? How did we find out this for the state of Massachusetts? Because somebody would ask the agent, meaning the agent, Avaamo's agent, AI agent, do you have group appointments? Mm-hmm. Obviously, the agent says no, and the call drops. But so we're able to look at what was the last question asked, and you see a whole bunch of these things, because we can decipher now, due to transcription technology, what was the last question asked.
And I think it's about, again, the hyper-personalization to the different patient groups. I think it's just a matter that we have never been able at healthcare with the full demand to understand what are the different behaviors and expectations. Different patients from different cultures also have different preferences on how they show up for healthcare, when they go for appointments. So all of these kind of things, if we can use this information and really feed it back, we can cut down on the cost for sure.
And that's a key point, because none of the breakthroughs will be adopted unless they reduce the cost and reduce the complexity. If it adds more complexity to an already challenged system or increases cost, no matter how important or life-saving it is, it will not be adopted.
Well, there's been a few questions, so thank you for pitching them in. Maybe something really relevant to this last thread is, what techniques can be used to ensure the accuracy of AI used in healthcare?
That's right in your zone.
Okay, so I think, like one of the interesting things that has happened is Nigam Shah is a mentor, and he's a key scientist at Stanford, but he talks about the patient timeline. We don't use the general models to kind of make,
That's right.
Predictions. So if you think of the EHR of the patient, you have a timeline, and the moments you show to the hospital or to the appointment, we just capture a small part of this data. But if we train models, so they train the foundation model just based on EHR data, and the rationale here is EHR is a different language than English, and you can think about it in all of those different aspects. These are different languages. So if you train the models on this way, these models tend to outperform and become very accurate, and we conduct a large number of silent deployment, evaluation, and they stay to be robust. So I think it's a moment of trying to understand what is the data structure and seeing actually that these LLMs can pull information from the patient EHR in less than a minute. So this is very powerful, and it's very accurate and often consistent. I think the main problem is the mess in the EHR and how things flows into the EHR. So think more.
Yeah, I think the question reflects what's in the market today, right? You can't just take healthcare information and just feed it into an OpenAI and add up all the tokens. It just doesn't work, right? It's not the way. So I think we call this small language models or domain-tuned models. And like she said, it's proprietary information. So you got two parts of the equation. One part of the equation is it's proprietary information, fine-grained, and the same questions are being asked, including the edge use cases. And when you go through 3 or 4 iterations, it's very, very precise. So the concept in what I call the general purpose retail model of precision and recall, that's a given. There's no a lot of people ask me, oh, are you getting 98 accuracy? There is no 98, it's got to be 100%, right? Otherwise they're going to get sued. So that's that's why healthcare is so hard, and healthcare is very, very domain specific. We do even specializations. So for example, for colonoscopy, we run a completely different model, right? That doesn't have anything to do with scheduling. So for colonoscopy pre-admission PAT, which is a term that's used, that's a different model. So at any given point in a large provider like a Duke or a Johns Hopkins, a company like Avaamo is running 20, 25 models, small, so on and so forth. So that's a technique.
If I can give one example, so we see large language models, for example, and Gemini, ChatGPT, and all of those multimodal. So in medical imaging, for example, we see that they are very powerful, but again, we believe that the fundamental multimodals that are going to be deployed in healthcare are going to need to be based on training data that is completely healthcare in terms of medical imaging. But what is these models are really powerful in is we used to need thousands of data points in order to be able to train a model that just function on X-ray, a model that just function on CT. And now we can kind of like use those multimodals to train it on MRI, CT, X-ray, and then fine-tune with just a small percentage of a data to kind of get it to a task. So that has reduced the cost and amount of data that's needed to use those type of models in healthcare.
Yeah, and you know, it even goes further, right? Because colonoscopy protocols at Duke is very different from colonoscopy protocols at Baylor. So it starts getting very granular in that sense, you know? So general purpose retail model training techniques don't generally work.
Well, and you need to put the layer of being age appropriate and culturally diverse
Oh,
and
yes.
culturally appropriate. So there's a lot of layers of complexity, both
That's right.
horizontally and vertically.
That's right.
But we're up to the task, aren't we?
They're trying.
Well, as everybody in the panel agrees, the technology is making significant advancements. And one of our questions is, how do we get organizations ready when it might take jobs?
Well, that's really, and I'm going to be politically incorrect, right? So let's say it. The healthcare system is so increasingly complex that if you ask a CEO of a healthcare system, in fact, he told me this, they run on grocery store margins. Most healthcare systems run on grocery store margins, 5%, 4%, whatever, right? So there's a huge focus from the business people on cost. And if you're a non-clinician, there are going to be jobs lost.
Well, and you're talking about the largest healthcare systems.
That's
I know for the customers of the company I worked at, regionals, they were 40% of them were -5, -7. That was their margin. They were losing money.
This might be a tautology, but I don't think we have to look to jobs being lost. There's going to be jobs retooled and repositioned.
I don't know about that.
No, I think, so here's one point where, for example, we just have this in Stanford Healthcare. So the program we have developed is you have a lot of like technology digital solution at Stanford Healthcare, include people who are work in operations, cybersecurity, and many other models. They do a lot of tedious tasks. Billing is a tedious task. But it was a matter of, you know, a leadership decision that we wanted to make sure that employees feel empowered to use AI in creative way to improve their productivity. And I think one component of it is we used to talk in medicine about lifelong learning, but I think everyone is going to be lifelong learning and really upskilling their skills to be, you know, available in the market. So it's a matter of how you can use the technology to your advances to keep being updated. And I think one of the main component is some people who work in the administrative job are really concerned around that. But can we understand what makes their job much better and more passionate so that they are more productive and let them use the technology to advance that? I think that's the main component of even how we are going to improve the administrative aspect of healthcare.
And they are the experts of their job.
Well, if I may respectfully disagree, that person who comes to you in the clinic and makes you fill in that form for the 5th time with the same crap that you wrote the last time, and then sits there in front of you while you're waiting and enters all that into data entry, that job is gone.
Yeah, I
Well,
think
the job may be gone, but that doesn't mean that the individual won't
Oh,
have
individual is a separate issue. So, like I said,
I think forms and things like that, definitely for sure. But I think the level we're talking about is healthcare runs on a large proportion of administrative staff. Physician nurses represent a smaller portion of that. And so even though we have like agents and even though we have models, we have to make sure that, you know, they're integrating correctly. There's a lot of different departments have different IT systems. And so how do you think about the people who are working in those kind of departments and how we kind of make sure that they are, you know, feeling that their job is still...
no, absolutely.
Yeah.
But I'm in the business of eliminating jobs, so.
Yes,
That's
automation.
how-
So that's why we're not
I would prefer you to say retooling a job.
I mean, it's just a reality.
Well, I'll give you an example from the revenue cycle business that I came from. When you do something in process claim status or prior authorization, that usually takes about 5 minutes. And using automation, we got it down to under 30 seconds. And we had our AI engine identify the 90+% of claims that needed to be processed automatically based on a set of rules. And so we presented the billing specialist a lower number of claims that they could logically handle. And if I may put you on the spot, Alaa, could you share with the audience just for a minute your background coming into AI, because I think it shows a lot of promise.
Okay, so try to make this brief. So I actually did my undergrad in kinesiology and health science. I was a bench scientist focusing on mitochondria and the effect of exercise on chronic disease and how that leads to improvement. The moment I got off the lab to work with patients, older patients, and do exercise coaching, I find how difficult it is. And I went to the healthcare, and I find how healthcare is a mess. And the global burden and budget keeps going up, and there is no improvement in outcomes. So my PhD focused on understanding what is patient-centered care and why the healthcare system keeps failing at operating and delivering. So there's, we have not been improving the experience nor the clinical outcomes, and the cost has been going up. So something is going wrong. So my PhD has focused on how I use big data to understand the different patterns and how actually the organization and infrastructure of hospital can completely lead to different patient outcomes on the long term. And if we want to use AI to improve population health, if we want to predict outcomes, we need to improve the data infrastructure. I was very fortunate to have great mentors, Matt Lundgren and Kurt Langloss and other people at Stanford who saw that, it's very important to address the data aspect. So I joined Stanford and I focused on data quality and medical imaging, working with clinicians to understand, even the smallest thing. I can say it's a breast cancer, but different radiologists are going to draw very different circles. That is just mind-blowing, because which one do you scale? Where do you get to consensus? So I figured out I spent 70% of my time preparing the ML pipeline compared to the training aspect. And even with large language model, we have been running into the same issues. So this made me very interested to work with computer scientists, engineers, to understand their perspective on how to develop models, go back to clinicians, and try to translate this into actionable instructions for computer scientists and software engineers.
I love your focus on data, and it reminds me of the statement, if you don't have data, you just have an opinion.
Exactly.
There's a key point that she made. Like when I talk to people, everybody asks about the fine-tuning part. Because, general purpose models is all about fine-tuning. Actually, what she said is the most important thing, the pipeline. That's what matters. When you're dealing with proprietary data, the pipeline is what matters. The fine-tuning is just like, cherry on the cake. So I think the point I'm trying to make is there's a fundamental difference in healthcare or any other kind of area where proprietary data is paramount, and the way in which you do AI, the way in which you prepare the pipeline from your general purpose retail world, right? So the pipeline is what matters the most. How you clean it, what you're putting in it.
But isn't that just data in, data out? So if you got garbage in, garbage out? Tell us more.
No, it's different weighting of priorities.
Different weighting, the biases, the labeling, everything matters, and it's at a very fine grain. Like I was saying, right? Colonoscopy is very different from ophthalmology, or, PAT testing. Everything is I don't know, I'm using the word very different, but it is. It's very different.
When you design a system, you make choices, and we have to make choices based on the priorities of the environment it's being designed for. And you're absolutely right. Healthcare is very different with different constraints and different rules and different regulatory backgrounds and different privacy level of concerns. It's a very different zone than other parts.
That's right. And even we hear a lot of, there's another anecdote. We hear a lot about, we should worry about the bias. Sometimes the bias can work the other way around. Mm-hmm. So in a hospice, they rate the providers on empathy, and there are all kinds of guidelines. Now the issue is the quality supervisor is from Alabama, and there's a quality supervisor from New York. And the quality supervisor from New York rating these providers or technicians or helping these people has a different view on what politeness and empathy is. And so what we found is when we were using AI to rate them, the AI rated them without bias. But the human bias was actually more when you're rating empathy and sentiments. So, it's not easy, this stuff.
I think I was going to mention, I don't know how many people are familiar, but the NIH has been putting a lot of funding into research that of high quality data, specifically All of Us database. So this include if you want to build a multimodal that's going to succeed, it's in the All of Us data, but it's just, you get access to the data. The government has been investing in building enclave environment where researchers from different institutions can actually build the models without having the data out. And at the same level, we kind of going back to data interoperability. So the same patient visit is coded differently across the different hospital. And big part of that translation before building the model is how do we make sure this is defined consistently across those different data curation process.
Well, one of the questions that just came in is healthcare is really sick care. So what can AI do to help it be truly healthcare?
I love that question, and I think we start with wellness. We need to help, and this is where the engagement that we can do by personalizing the motivations. There's techniques in the Stanford Virtual Human Interaction Lab. We have a paradigm where you can have a dialogue with your future self, and your future self can give you feedback on the choices you're making. It makes it a little bit easier for people to do the right thing in terms of exercise, because we never close the feedback loop with our other processes. But I think to make it healthcare as opposed to sick care, we have to get ahead of the curve, intervene earlier, teach people wellness skills, and also understand the individual, personalized medicine, because often our healthcare system is not fun. And I'm not saying we should, emulate what our colleagues in the movie and gaming industry do, but I think we can learn from the way they personalize engagement and make healthcare something that we do not to avoid problems later in life, because nobody, it's hard to think about that, but to be healthy in the moment.
No, I was going to say it goes back to incentive. So what is the incentive to move care from being sick care into health care? Well, it goes back to the model of care. The value-based care is based on, patient visit coming to hospital. But if it's reversed to be that it's based on population outcome, you can see, for example, the different insurance policies between Kaiser Permanente or healthcare or Stanford Healthcare or different insurances. But you can find that one example is looking at their incentive is prevention care. And if you're targeting to prevention care, you're going to get to healthcare. But if you're focusing on addressing the acute and severe cases, you're going to stay in sick care. So I think there's a need for a shift in model and how we think about that. And I think AI is just making, with all of what we have seen, healthcare is going to be outside of the hospital most of the 70% of the time. And so how do we make that this is integrated and efficient? Because this can actually make the hospital focus on the patients who need to be in the hospital.
Yeah, it's a broader problem. I don't think AI is going to solve it. AI can't solve world hunger. I mean, it's an incentive problem, right? The healthcare system is not incented for preventive care. It is incented for sick care, right? So that's just the way it is. And we've got to change it, but that's kind of not just AI.
Biased by design.
Well, but we're seeing the tech titans come into healthcare.
That's right.
And they know how to move fast, and they know how to promote engagement, and they will focus, I think, first on wellness. And so I do think that there is movement of coming up with enabling applications that will help us on that side of the equation. And we have to. If we look at the three big crises we have right now, we have an aging population. We're all going to live decades longer than previous generations. And but there's the issue of cognitive aging and other issues with aging. We have a problem with our youth and mental health. The pediatric care and children's hospitals are overwhelmed. And we have a burnt-out healthcare system that's crumbling. And so I think we do need to move fast, and we need to embrace things carefully. But I do think technology is on our side.
If I can share a quick example. So a couple of weeks ago, someone met me at a conference, and then they followed up with me, and they're software engineers. They were very interested in ethics, so I was very kind of interested software engineer coming to ask me about the ethics in the LLM development. And then it turned out that they're trying to build a mental health model that that is specific to software engineers, because they're specifically facing certain aspects of the workforce that makes them feel burnout. So how the chatbot can actually be to their service to be, a mental health counselor, that they can share the things that they cannot share outside. So that was, to me, was, innovation, and the ease of developing these things will make this, much more kind of like, we need to vet that the mental health chatbots are really safe, but they can go a long way in improving people's.
Well, we finally have some new tools. Heretofore in psychiatry and psychology, we've relied upon subjective reports, self-reports, or observational
Who's
reports.
going to carry the malpractice insurance for that chatbot?
I think it's a wellness product. It's going to be under the wellness products. So I think from a regulatory perspective, there is no agency that's currently putting its hand on how Gen AI is regulated, but there's a lot of considerations, and this is going to be.
Well, and employers want to keep their workforce healthy,
Yeah.
and so that may come from that.
In the software domain that I come from, this is a really relevant topic for me personally, because I've dealt with employees that are burned out, and then you've had to work with them to keep them productive and engaged in some way, and it's a really difficult problem. So thank you for doing that. One of the questions that came in was, how do we keep engineers engaged with clinicians? Is there a communications gap?
I'm having that problem right now.
I'm 100% kind of like, we face this in every single project, and that clinicians come and they say, we want a model that does this, X. And then we have to run with what X is from the data and develop a model. But when we come back, oh, this is not what we intended. Have we all sat around the same table, defined things the same way? They define it in very different ways. Plus, software engineers and machine learning scientists are not often on the healthcare side. They do not have the information and context. Again, that patient timeline, you just see a small picture of it. The physician is able to see, oh, this is why it's not going to work. But this information that the physician had was not communicated. So I think
It's a design challenge, and the interface between the clinical community and the carpenters and the engineers needs to be the designers, the architects. And so I think, to me, it's establishing the right sort of design-first approach.
So Ram, you mentioned the problem, but you haven't said anything. What's the problem?
The problem is simple, right? To what she was saying, clinicians find it very difficult to express the outcome they desire. And engineers want an MRD, right? Or a PRD, right? Where it's clearly enunciated. So building products for clinicians is a little bit of an iterative challenge for me too, right? Like the outcome we understand, but the steps to get to the outcome is a discovery model.
I was going to just say that at Stanford, so part of the data science team, they developed a framework called FIRM, but the reason this was very helpful was because the report is designed that any champion who's coming for an AI request to define exactly what is the problem and how this is going to affect which percentage of the population and what's the expected measurement. And it takes us a lot of amount of time to do interviews and intakes, but once this problem is set, you kind of know which data you're going to look at, you know what are the exactly outcomes you're looking for, and sometimes you can find that, many people come to you with ideas, but it does not necessarily improve either the quality of care or the cost. So then it also gives you information into whether this is something you want to invest in or not.
Well, I sense there's some product owners or managers in the audience who are scratching their heads if they're not in healthcare and looking at Ram and saying, well, yeah, this isn't a no-brainer. I'm supposed to go out and do customer discovery, identify a value proposition, but I have found in my limited time in healthcare that it's a new concept.
No, that's not the point. That is not the point. So the question is, the clinician is not a business person. The clinician wants to maximize the time they spend on diagnostic procedures, right? So the issue with designing software is, what's the outcome? Is it a cost outcome? right? Which is where you would invest, for example. Or is there a positive outcome for somebody, which is not clear, right? But so I think that's the problem in designing software for clinicians. It's not that, hey, you will eventually get the requirements. You will go through multiple, but what's the outcome?
What I hear you saying is we need to do the financial engineering in our design, as well as the clinical engineering, as well as the device engineering, as well as the anthropology of the clinic. But that's a matter of design, and it's an expensive process to do it right, but that's how you do it right.
That's right. So then, in this age and time of startups looking for capital, patience is not a virtue that startups have, right? We want to put an MVP out and somebody wants to write a check. So.
Well, I'm going to just finish with Alaa as an example, and I'm not trying to embarrass you, but earlier you'll recall we talked a little bit about a fear, and I would respectfully suggest to you, don't operate out of fear. It's very natural to be anxious about some of these developments, but you could see from Alaa that she has found her own niche, that she has not taken the traditional path, though AI, one could argue AI went back to the 1950s, right? But actually this morning she was expressing to me, I wish I was a data engineer at some level, or I wish I was a software engineer. And what I found in my conversation was that she's actually found her own niche and adapted to this new reality. So let me finish with a comment from the audience for our panel, which was, love to hear each panelist's thoughts on incentivizing preventative care as opposed to sick care. Thank you.
Well, I think that was a question of what,
Yeah. Oh, okay.
what you just said was a question to each of us.
Oh, go ahead, please.
Yeah, it's a complex question, but I think it goes back around, policy and decision making. And I think there is a lot of physicians who are, rallying for reimbursement, but and changes in the CMS. And I think the fortunate things is AI is pushing CMS to kind of think of different models of payment. And so hopefully this is going to lead to improved outcomes. I think the incentive here is, budget and spend care on healthcare. And if we can show that, we need to focus on preventative healthcare in order to stay within a specific budget, that might be the incentive to push. I think here's where, you find that math and algorithms can take you so far, but policy and politics kind of control a long portion of it. It's also kind of interesting to see when you attend medical conferences how physicians actually face a lot of challenges, even talking about how they get reimbursed as physicians. And there's nurse unions, so there's different aspects of how the healthcare reimbursement is a complex process, and it's going to take, different champions of people to kind of push the status quo at the different levels. Please.
I think to improve healthcare as opposed to sick care, we focus on the individual, and to incentivize that, it's engagement. And to do engagement, it depends on the individual's background and culture and age group and personality. But we can look to our friends in the entertainment industry, in the gaming industry, and even the gambling industry to how they go about engaging people, keeping them coming back to do what they, in this case, it might be to come back and watch the television program. But there are ways to give feedback to individuals, but you have to understand their values, what motivates them. So it's no one solution for any large group. It's how do we understand the individual and what engages them in their health care.
I think about it that this is something that AI is not going to kind of make a difference. AI is going to make a difference in longevity. AI is going to make a difference with tools that you're going to get to understand what your blood pressure is today. But to change this preventive care model, that is a major policy thing. Policy, what does that mean? Well, 42% of people in the United States get their health care through the employer. So the incentives should come either from the employer or from the Medicare plan, which requires major change in policy, because that will generate a behavior change.
Very good. Thank you so much for joining us this afternoon. And please give it up for the panelists.